inviting me to speak on this very important topic of cardiac sparing techniques used in breast cancer radiotherapy. So, as more and more women survive this disease, it's also becoming increasingly crucial to find ways to lessen the toxicities of cancer treatment. So, first, why do we need cardiac sparing techniques? So, this was a study from the New England Journal of Medicine that was highly publicized back in 2013. It's a population-based study of over 2,000 women in Sweden and Denmark looking at breast radiotherapy from 1958 to 2001. And it demonstrated that for every increase in 1 gray mean heart dose, there was a 7.4% increase of a major coronary event. So looking at a more recent publication from the EBC-TCG, who conducted a meta-analysis published in the JCO in 2017, which aimed to estimate the mean absolute risk of modern breast cancer radiotherapy this time. So they reported that the mean heart dose does correlate with rates of both cardiac deaths and risk of coronary events, showing that with modern radiation doses and lower mean heart doses of less than 4 gray, the estimated absolute risk of cardiac mortality is only less than 1%. So this is really driving the standard for us to do better in terms of reducing toxicities, particularly to the heart. So there are 3 different concepts for reducing the heart dose in breast cancer patients that can be employed. First is reducing the target volume, as in partial breast irradiation. Next is maximizing conformity to a given target through the use of modern techniques such as IMRT and VMAC and Protons. And third is displacing cardiac structures out of the radiation field. So for example, through prone positioning and use of breath hold techniques. So I will be going through these techniques one by one, discussing the advantages and disadvantages of each. So, but first, a precaution that I'd like to mention is obviously breast RT has to be individualized. So it depends upon the target that the physician has chosen to treat. So for example, chest wall only versus chest wall with regional nodal irradiation. It also depends upon the patient's anatomy. So we all know there are different variations in chest wall technique, for instance, or there are different variations in the depth of the IMNs, etc. As well as patient-specific factors like comorbidities and chemotherapy-induced toxicities. So it really requires the team of therapists, physicists, and physicians to be at the actual simulation planning to make the final decision. So focusing on the first concept, reduction of the target volume using partial breast irradiation. So of course, the idea behind this is the more confined or smaller the region of target is, the lesser is also the toxicities to the nearby organs at risk. So recently, partial breast irradiation, particularly accelerated partial breast irradiation or APBI, has been gaining a lot of attention. So it is the delivery of hypofractionated radiation therapy to the lumpectomy cavity only, rather than the whole breast, ideally in less than 5 to 8 days after lumpectomy. And the aim is to achieve local control post-lumpectomy that is equivalent to or non-inferior to whole breast radiation therapy. So, but the first thing to recognize about this is that there's a wide variety of approaches for doing this technique. So there are multiple brachytherapy techniques that are available, and the most commonly used is the balloon-based catheter approach. So fewer centers are also utilizing multi-catheter interstitial brachytherapy simply because of the expertise that are required for this approach. Then there's also the intraoperative brachytherapy or IORT. And then, even within external beam radiation techniques, there are also a variety of options. So the most commonly utilized option is EBRT using 3D conformal technique, but there's also data looking at IMRT. So the first thing to evaluate within your own practice is what are the different technologies that you may have access to in determining whether and how to use APBI. So, and there's data to support the utilization of all these different techniques for partial breast irradiation, and what is appropriate is going to depend on your patient, your expertise, and your access to technology. So now there have been about 4 phase 3 randomized trials with non-inferiority design demonstrating that in-breast recurrence from APBI is non-inferior to whole breast irradiation, as you can see here. So in-breast recurrence, which were followed up between 5 and 10 years, is quite low, In most of these studies, it's less than 2 to 3%. In regional recurrence, it's also similar between APBI and whole breast radiation arms. So of note, they use various APBI methods with multi-catheter brachytherapy used by the NIO Budapest and the JEC ESO trial, while the University of Lawrence and the Canadian Rapid trial each using external beam radiation that again showed similar non-inferiority of APBI compared with whole breast radiation. So overall, what does this mean? So when we think about what has been recommended back in 2016 for the updated ASTRO consensus statement for APBI, as you can see here in this suitable group, and if you look at this, the 4 non-inferiority trials presented earlier really confirmed for the most part that these recommendations were good for stage 1 with less than 2 centimeter lesion, hormone-positive breast cancer patients. And this is what constitutes the vast majority of the patients studied for APBI. So again, you should look at the population of patients who you see in your clinic. For me, in our country, probably the majority of patients will not be suitable for APBI and will fall into the unsuitable category because we mostly see locally advanced cases. So when you see a patient, the first thing to think about is this patient potentially a candidate for partial breast irradiation based on these criteria? So for me, I would consider 3 factors for each patient when thinking about APBI as a consideration. So the first is the clinical criteria. Is this considered a safe, oncologically effective approach based on the guidelines and randomized trials? Second is the availability of technology and expertise in your own center. And the third is individual patient criteria, which is equally important also. So for example, the anatomy. Because even if you have a patient that would be considered suitable, the anatomy would still influence whether APBI is appropriate or not. So for example, it's the ability to meet those constraints. For instance, in EBRT, you want to make sure that the surgical cavity is relatively small compared to the full breast volume. So if you have a patient with a small breast and a relatively large seroma, for example, you'll probably have a difficult time meeting the constraints. So the patient's anatomy would also be a consideration. So the second concept is maximizing conformity to a given target or PTV using advanced technologies like IMRT, VMAC, and Protons. So we all know that we've gone all the way from 2D planning to 3D CT-based planning, but in the past years, the external beam planning techniques have really focused on beam modulation. So all the way from field-and-field segments to IMRT and then to VMAC. So the field-and-field technique uses aperture-based optimization wherein we optimize the intensity of the radiation within the traditional tangent fields alone. So the advantages of this technique is no target volume needs to be drawn, and yet you can reduce the dose inhomogeneity and decrease acute toxicities, which is significant in the paper reported on by Beaumont. But the disadvantage, however, is you don't get very much organ at risk sparing at all. So others have looked at inverse planned IMRT using multiple non-coplanar beams, and obviously this gives us the advantage of being able to place these steep dose gradients at the interface between the heart and the target. But the disadvantage is we spill a lot of low dose to the contralateral lung, heart, and the breast, and there's a longer treatment time to consider. So the British Columbia group, who extensively investigated IMRT and VMAT for breast cancer, has reported on the use of IMRT for treating left-sided breast cancer when regional nodal irradiation, particularly to the IMNs, is needed. And they have shown that while IMRT does significantly improve conformity and homogeneity, it does spread more low doses to the heart and lungs. And so they have set themselves a threshold wherein they only use IMRT if they can achieve a decrease in the V30 of the heart of more than 10%. So this slide shows that because we can bend the isodose curves with IMRT, even if we add a 7 millimeter margin as required, we can still achieve heart and even lung sparing. So with IMRT, we can significantly decrease V30 of the heart and lung, but obviously the V10 and lower isodoses are increased. So this needs to be very carefully weighed against consequences for each patient. Also, the British Columbia investigated VMAC, and this is a planning study where they focus on the use of shortened arcs. They only use two arcs, none of which go through the contralateral side. And their results show that VMAC can indeed mimic IMRT while providing lower monitor units and delivery time. However, the healthy tissue volume percentages receiving 5 gray were also still significantly large. So for me, I think VMAT or even IMRT can be considered on a case-by-case basis and should not be offered routinely. So we have what we call the VMAT trade-off, showing that we can get really very nice homogeneity and rapid dose fall-off, but at the cost of a low-dose bath to other structures. So next, for the use of protons. So Harvard reported the use of protons for patients who require regional nodal irradiation. So protons are sort of ideal for this because they have a limited range. So if we could get the radiation to end right at the interface of the target and the heart, then this would be really very ideal. So in their study, they were able to achieve very low mean heart and lung doses. So for example, for the heart, mean doses of only 0.1 to 1.2 gray were reported. So there's in fact a large randomized study, the RADCOM trial, looking at protons versus photons for breast cancer patients. But we don't know if protons really result in fewer long-term cardiac complications, which is the purpose of this publication. But we can see that the symmetry of protons can be very appealing. But obviously, proton is not something that's going to be widespread. So lastly, for the third concept of displacing the cardiac structures out of the radiation fields, we have the prone technique and the use of the deep inspiration breath hold technique, or DIBH. So first, let's discuss prone positioning. So some centers in the US have adopted this technique to address the issue of positioning women with very large pendulous breasts. So prone positioning really affords dosimetric advantages, including organ at risk sparing, improved dose homogeneity, and in minimizing breathing motion. So this illustration demonstrates how a good prone positioning can really move the breast target away from and completely eliminate any heart from being irradiated in the field. So another advantage for women with particularly large pendulous breasts is improved homogeneity. So this is the same CT scan of a woman in prone and supine positions, and you can see that the separation of the chest wall is dramatically reduced in prone positioning, and what you end up is having a cylinder-like shaped breast, which means that you can get very good homogeneity within this breast tissue. So this is a study which positioned 3 women prone, and then they were positioned supine, and studied them with 4D CT scan in order to look at chest wall motion. And it really showed that the very minimal chest wall motion we typically see in the supine position, which is only under 3 millimeters, was virtually eliminated in the prone position. So this is another advantage of prone positioning. So are there any disadvantages? Well, there may be if you're trying to cover the axillary nodes. And in certain patients, the heart actually does fall closer towards the chest wall. So this is a slide from a paper from the NYU group, which shows that when the breast falls away from the chest wall, it also tends to fall away from the axillary node, so that these nodes in traditional fields are not going to be adequately covered compared to supine positioning. And as mentioned, in select women, the heart can actually move anteriorly. So this is a supine CT scan, which shows that the heart is not up against the chest wall for this particular patient, but when she was positioned prone, her chest actually falls forward. So there are patients wherein prone is not the right positioning for them. So the NYU group studied the question of who is a good candidate for prone positioning, and they reported that in their patient population, prone is always better in right-sided breast cancer patients, and only in about 85% of left-sided breast cancer patients. So, however, their study did not include patients who require regional nodal irradiation. So in our country, since most women have the average size breast and most require regional nodal irradiation, the prone technique was not something we have actually adopted. So next, let's talk about respiratory motion management in breast cancer patients. So as mentioned earlier, the respiratory motion in the supine position is actually very minimal. So according to this study, only about less than 3 millimeters. But what if we could use the inspiration cycle to our advantage? So this slide from a publication from JAGC in 2007 shows the dramatic change that we can see in the position of the heart. So the red arrow here shows the separation of the distance between the breast and the heart. And with an inspiration technique, as shown in the picture on the left, the heart clearly separates away from the chest wall. So this slide shows that when a patient takes a very deep breath and holds that position, the heart actually moves inferiorly and medially so that it's away from the IMN target as shown here in green. So in fact, the lung also expands, so there's less lung in the treatment field. And this illustration is just showing that those changes actually do result in improved DBH parameter, especially for the heart. And there have been several studies comparing DIBH to end inspiration gating, end expiration gating, and free breathing, and a significant reduction in the mean heart dose have always been shown. So DIBH actually represents the best explored cardiac sparing method, consistently showing a significant advantage in heart sparing in breast cancer patients. So briefly, I would just like to share our institution's own cardiac sparing technique. So we use voluntary deep inspiration breath hold with the help of the Varian real-time position management, or the RPM system. As you know, it uses a reflective marker block that is placed on the patient's anterior abdominal surface, typically midway between the xiphoid process and the umbilicus where there's maximal displacement. So this marker block is illuminated by infrared emitting diodes, and there's an in-room camera that is placed at the foot of the couch to accurately detect the reflective markers. So therefore, we can choose a particular phase in the breathing cycle when the radiation beam will be turned on. So for breast cancer cases, we use deep inspiration, and we set our threshold based on the patient's ability to deep inspire, which we get the information from during planning and simulation. So the radiation beam will turn on only when the patient deeply inspires, as detected by the RPM system, and the radiation beam will shut off automatically should there be any discrepancy. So here's a closer look at the setup. And here is one of our actual patients at setup. So this is the breastboard that we use. We put the usual wires around the breast tissue and the scars. And this is the reflective marker block that we place on the patient's upper abdomen. But the first thing we do is assess if the patient can tolerate and sustain a deep inspiration breath hold. So first, we coach the patient and let her practice if she can deeply inspire for at least 20 seconds. Then we check if the inspiration is deep enough. So we do this by putting anterior and lateral marks on the skin. So here's an example of the lateral marks that we put. The first picture shows a mark during free breathing or normal breathing. Then we ask the patient to deeply inspire and hold it for 20 seconds. And then we put another lateral mark. So the difference between the two marks should be at least 1 centimeter. If successful, then we proceed with the CT scan with this kind of setup. So we take 2 CT scans, one during free breathing and one during deep inspiration. So here is the actual CT scan of one of our patients. So one in free breathing on the left and one in deep inspiration on the right. As you can see, the heart really does separate from the chest wall. So the contours of the target and the OARs and the planning and setting of the fields are all done in the deep inspiration scan. So we just use the usual mediolateral tangential fields for most of our patients. So this is the actual DVH of that patient, showing very good breast coverage while the heart is well away from the high dose region. So for this particular patient, we used hypofractionation with a dose of 4,200 centigrade and 16 fractions to the whole breast with a 12 gray boost to the lumpectomy cavity. And the mean heart dose that we got was only 1.35 gray. So to summarize, I just want to highlight that there are so many different options to choose from. And what you have available in your own center and your expertise is basically what's going to drive what you may do. But with respect to positioning and immobilization, I think the idea behind this would be that we want to optimize basically the anatomy to help us overcome the fundamental limitations of dosimetry. And then we can also look at modality and technique to help us maximize the actual potential the dosimetry has. And lastly, of course, as mentioned, patient factors are also very important. Thank you.